Good afternoon, everyone, and welcome to the September edition of the Hospital Medicine Monthly Update. This is Fabienne Moore, Vice President of Physician Development, and I would like to start by not only welcoming you, but also thanking you for taking the time out of your busy clinical days to join us for these really important updates to our practice. Today's presenters are going to be Greg Johnson, who is our Chief Medical Officer of Hospital Medicine, and Nate Ruck, who is our Chief Medical Officer of Emergency Medicine. For your reference, you'll see the bios of all of the faculty and planners, and those will be available in the deck once it is posted on OWL. And I'll just reiterate our learning objectives. The whole point of the monthly update is to create a conversation that will allow us to continue to commit to building evidence-based guidelines into the management of patients with COVID-19, as well as all of our patients with common chronic diagnoses that we see. And now today's agenda. Nate is going to start us off with a reflection, and then he will keep it moving, talking with us about some of the latest research on endovascular thrombectomy. As is our common practice, there'll be time for discussion, questions, and comments for Nate's article, and then we'll turn it over to Greg, who's going to be talking about COVID-19 and thrombotic or thromboembolic disease. And I'll just share with you all a comment Greg made in our prep that really resonated with me, which was that COVID is in many ways as much a vascular disease as it is a pulmonary one. So a really important discussion there. It's a topic that we've addressed in previous webinars and is absolutely worth coming back to again today. We'll then have time for questions and comments about that article, and then we'll close with our traditional reminders about resources available to you for well-being and support. As always, the webinar will be recorded. You will have the opportunity to refer back to it. And please feel free to enter your questions into the chat box as we go along. And when it comes time to pull up for Q&A, I'll be able to retrieve those from the box. With that, Nate, I'll turn it over to you for our reflection.
Thank you so much, Fabienne. Our reflection today comes to us as a series of 16 tweets, which were sent out by Dr. Nick Sawyer. He's an emergency medicine physician at University of California, San Diego, in academic practice. And it begins, early this morning while on shift in the ER, a first-year emergency medicine resident, just 2 months into her residency, came into the doctor's work area and tapped a more senior resident on the shoulder. "Can I have a hug?" "Of course," said the senior resident as she stood up and hugged her junior colleague. The first-year resident was in tears. Her eye makeup was running down her face, blackening the inside of the surgical face mask she now had hanging around her neck. The thought of masking and social distancing never even entered my mind. They walked around the corner to talk, and I was quick to follow to see if I could be of any assistance. Standing at a distance, so as not to intrude, I asked, "Is everything okay? I don't want to interrupt if you'd like some privacy." "No, it's fine," said the junior resident. "I just had a really rough night." "She's on MICU," the senior resident added. Knowing we had 19 patients with COVID-19 in the MICU, I asked, "How are the COVID patients doing?" "They're really sick and they're dying," the junior resident responded. "We had a totally healthy patient in their 30s die from COVID last night. It's really hard," she said. "I'm so sorry," I said. "I know it's hard. I know how hard it is caring for critically ill COVID patients, and I know you all did your best." The junior resident nodded in agreement, but there remained a deep look of pain in her eyes. "I know," she responded. "Are you going to be okay? Do you want to speak with our resident psychologist?" I asked. "She's really good," I went on. "No, I'll be okay," she responded. "I just need to get some sleep. It was just a really long night, and I got to get back tonight," she said. "I understand," I said. "Feel free to reach out to me if you need anything whenever," I concluded. "Thanks, I will," she responded. I left the two residents to talk and walked back to where I'd been sitting. As I sat down, my mind took me back to a night in April when I was volunteering in Queens, New York City, caring for critically ill COVID-19 patients. Earlier that evening, we had a patient on our team die. As is often seen in end-stage COVID patients, his lungs had become stiff and non-compliant, making it impossible to adequately remove CO2 from his body, which made his blood very acidic. There were no further changes we could make to the ventilator. We had tried everything. But the patient remained on maximum life support and he was not improving. We knew that he had no chance of survival. As patients' family members are not allowed in the ICU for fear of further spreading the virus, the patient's family had to say goodbye to their loved one in a way that can only be described as heartbreaking for all involved, over FaceTime. I remember leaving the hospital that night with tears running down my face, holding back to keep my composure. It was one of the hardest moments I'd faced as a physician, and it wasn't the last time I'd take my family through that surreal and horrible process before returning home to California in early May. This was the pain I recognized in the junior resident's eyes. I knew exactly what she was going through, but the difference is I've been practicing emergency medicine for 8 years, and she's been doing it for 8 weeks. This is the reality of the COVID-19 pandemic for far too many patients, their loved ones, and those who care for them. It's a dark reality, but it's the truth, and people need to be aware of the terrible reality of what is currently happening in hospitals across the nation. So Twitter's a new source for reflections for me, but that series of 16 tweets really resonated with me, and I used it as a reflection in an emergency medicine meeting, and I know it resonated with others. So I think we can make the awkward transition into the first article after that reflection. So the first article is from the New England Journal in May. This is a really interesting stroke trial. So what's happening here is it's endovascular thrombectomy with or without intravenous alteplase in acute stroke. And this is a non-inferiority trial sponsored by the Chinese government. And what they accomplished is really pretty amazing in terms of enrolling patients and the speed with which they conducted it. So this was performed at 41 academic centers across China. And in the end, they enrolled 656 patients, and they divided those patients into 2 groups. You can go to the next slide.
Nate, before we do that, do you want to make sure that folks are oriented to the flow code?
You know, that is a fantastic idea, Fabienne. So that kind of, you see that circular kind of pixelated thing staring at you in the bottom part of the screen. If you point your cell phone camera or a tablet camera to that, it should prompt you to link directly to the journal article if you don't have it in front of you.
We'll just give folks a moment or two, and then I'll advance the slide.
Yeah, no, so you can leave it here for a moment. So, you know, I think whenever interpreting, you know, research, it's important to know what the structure of the study is. And in this case, it's a non-inferiority trial. So, you know, really seeking to see if a new therapy is equivalent, you know, to an old therapy, not looking for, you know, improvement in any way. And I think it's also good to say a little bit about, well, what's known about this topic? You know, there are meta-analyses that suggest that endovascular thrombectomy alone is equivalent to alteplase plus EVT, but there really aren't any randomized trials on this topic. And, you know, no one really knows the answer of, does giving TPA prior to endovascular thrombectomy improve outcome? There's some potential advantages to giving TPA first. You know, one common complication of endovascular thrombectomy is distal embolization. You know, the stent retrieval devices that they use for these cases, you know, that's something that happens. Some have hypothesized that TPA will give, will lessen, will mitigate that distal embolization. Some people think that you'll get earlier recanalization if you give systemic TPA. Obvious disadvantages of TPA first are that, you know, systemic TPA, it's not really a targeted therapy, and you may have higher rates of intracranial hemorrhage. So the graphic that you see on the screen now takes us through the structure of the study. So what kind of patients do they enroll? This is by any definition, a super sick cohort of stroke patients. You know, the blended mortality was something like 18%. Initial NIH stroke scale was 17. The, you know, 17, yeah, so 17.7% mortality in the EVT group, in the EVT alone group, and 18.8% in the combination group. You know, just to put that in perspective, this is, you know, much sicker than your typical you know, stroke trial. The NINS trial, for example, had a average NIH stroke scale of 8, just to kind of emphasize that. So after enrolling patients, they divided them into 2 groups, the direct to endovascular thrombectomy or IV thrombolytics followed by thrombectomy. They did NIH stroke scale, they did a whole ton of follow-up imaging, and then they had providers that weren't involved in the acute stroke scale perform follow-up. They lost very few patients to follow-up. You can go to the next slide. So this is kind of, the visual abstract. And, as I said, they enrolled 656 patients. The study was conducted over a period of less than 2 years. They, all of the centers that were included in the trial had to perform at least 30 intravascular stroke cases per year. And they use standard alteplase dosing, of 0.9 milligrams per kilogram. And there's a table which we have in the appendix, which we don't need to show now, but which compares the characteristics of the 2 groups, and they're really quite similar. So, after adjustment, there's the odds ratio is 1.07, slightly in favor of endovascular thrombectomy alone. So, really the study showed that endovascular thrombectomy alone is non-inferior to alteplase plus EVT. And as I said before, death rates pretty impressively high. The 17.7% in the EVT alone group, 18.8 in the alteplase group. The rates of intracranial hemorrhage, slightly higher at 6.1% in the alteplase plus EVT group. Asymptomatic hemorrhage, super common in all species of stroke patients, especially those treated with lytics. And you could see the asymptomatic, ICH rates are pretty similar in the 2. You can go to the next slide. So how did they compare the 2 groups of patients? What they did was they mapped them into groups using the modified Rankin scale, which you see here. This has, its pros and cons, but it's really a very common rubric for categorizing stroke patients. But, really the knock on this is that the steps between criteria are pretty steep. Obviously it's never good to be a Rankin 6, which is death. But if you look at, the difference between a 2 and a 3 or a 3 and a 4, pretty big jumps between. If we move to the next slide, you can see how those 2 cohorts mapped out. And, this trial wasn't really powered to look at individual Rankin cohorts individually, but the short version here is that, all the groups really mapped out. And what jumps out to me is just how terribly sick this population was. In order to be included in this trial, you had to have either an intracranial carotid thrombus or an M1 or M2 thrombus in an intracranial vessel. So these are big, devastating strokes. Baseline NIH stroke scale very high, high mortality, high morbidity. And, so let's talk a little bit about, this is the first really in a series of articles. And I think we all know from the prior stroke literature and from practice that, TPA has a marginal effect. It certainly isn't a transformative treatment for stroke. And, so what are the drawbacks here? This is a large, speedily, well-done trial. It has a couple of drawbacks that we should talk about. So this was news to me, but in Chinese patients, there's a little bit of racial bias in this data, which may limit the generalizability of these findings. And basically, Chinese patients have a tendency to have a type of atherosclerotic disease intracranially that is not common in other races. And the authors pointed this out in the same issue of the New England Journal. There's a accompanying editorial which kind of goes through this in some detail. And they also have an audio, as the New England Journal has started doing, they have an audio kind of discussion with one of the editors that talks a little bit about that as well. And the other thing that I think is really interesting here is how many patients had clear vessels prior to endovascular care. And if you look at the patients that didn't get thrombolytics, 2.4% had recanalization. And, remember, these are patients that have large vessel occlusions, right? These are carotid artery or M1 or M2. And in the group that didn't get lytics, 2.4% of patients had continued or had recanalization prior to endovascular thrombectomy. If you look at the group that got lytics in the traditional dose, only 7% had revascularization. So the benefit of lytics is pretty small. And in turn, when you look at that, at that marker, at that recanalization, and it's really interesting. You look at that and you think, boy, well, maybe thrombolytics are just not that great. But I think there's another detail that may explain away some of that, which is that in many of the patients, they were so quick to do endovascular thrombectomy that the infusion was only completed in 23 of the 319 patients that went to the intervention group. And that, I think, is another thing that is potentially a drawback of this trial, is that they really, obviously, you want to get to the endovascular therapy as quick as possible, but in the vast majority of cases, they didn't allow the lytics to completely infuse. Another thing to think about here, and which makes this trial a little different than some other endovascular stroke trials, is that, and this may actually have biased the results against endovascular therapy. They didn't use an aspect score or some other scoring system to kind of talk about what's completed infarct versus what's penumbra when they divided the patients into groups and tried to choose, who was best for what intervention. That's a very common thing to tilt the table in favor of endovascular therapy. That was not done here. And we talked about the rates of hemorrhage. So I think you can go to the next slide here. So really, when it comes down to this, is this a practice changer in terms of an article? And does this research mean that, you should move directly to endovascular therapy without giving intravenous TPA? That's a complex question that, I don't think that this research completely answers. There are a number of large ongoing trials. There are issues with generalizing this to the population that we see in the US due to differences in the stroke pathology in Chinese patients. And there's also some issues with the way the trial was done. Typically in the US, the time to EVT for patients that are transferred is longer. Often the dose of alteplase has a lot more time to, circulate prior to endovascular therapy being done. So I think really the answer at this time is not yet, but watch this space closely for more data, and more data is coming, really quickly. I think the other thing that's really interesting, and this is another nuance in of China, is that this was organized by their National Health Service, but in order to be enrolled in the trial, the patients or their families had to agree to pay for the alteplase in advance or pay at the time of enrollment. I'm not sure you'd get that through the Institutional Review Board in the US, but that's how the trial was structured there. So it may have created some type of selection bias that needs to be considered. I think another thing to think about when considering the results of this trial is that, most of the endovascular thrombectomies, I think something on the order of 90% were done with stent retrieval devices. And there are some newer devices like aspiration catheters that are coming out. And there are small trials showing that those have better outcome. Another thing to keep an eye on is, I'm sure many of you saw the trial comparing tenecteplase to alteplase, and tenecteplase has, I think, a little bit better results, at least based on that research. So, and those questions, I think, will get more clear answers in the coming months as some of the large registry trials come out. So that's really my prepared content on this study. I see we've got some attendees. Anybody have questions based on what was presented?
Nate, we don't have any questions that came in while you were speaking, but let's give it a few moments. Okay, it looks like there aren't any questions for you right now. So we'll go ahead and transition to Greg and our second article. And of course, we'll be sharing your contact information at the end of the webinar, Nate. So if folks think of any questions, they can follow up with you via email.
Well, thank you for allowing me to participate. Thanks for the invite, and take it away, Greg.
Thanks, Nate. I appreciate your attending and presenting, particularly on a topic that very clearly overlaps our two specialties, emergency medicine and hospital medicine. We're all dealing with stroke patients. In many instances, our hospitalists are part of the stroke response team. And so the article is a very clear opportunity to figure out how we can collectively address those patients. So thanks again. We are now going to transition into our COVID topic, and this is the article that you see in front of you. And again, the QR code that Nate did, I thought was a fantastic suggestion. So we've added that, and we'll add that on an ongoing basis so that way people can access the articles on their mobile devices as they need to. But when we're thinking about COVID-19 and thrombotic or thromboembolic disease, this is a topic that we've addressed a number of times on prior webinars. And with the goal and understanding that this is a different type of study than what Nate did. This isn't, in fact, a study. It's a report that's in the literature. It was produced in June and was really intended to provide some additional guidance around what to do with COVID and the coagulopathic concerns that arise from it. So if we go to the next slide, the first takeaway in terms of what's in it for you and what's in it for your patients are, as I stated before, this is a common complication of COVID care. Alliteration notwithstanding, this is as Fabienne stated at the top of the webinar, the concern here is that we find in literature that lots of people are referring to COVID as much as a vascular disease as they are a pulmonary one. The second is that the coagulopathies, and not just the specially defined DIC-like COVID coagulopathy, but the thrombotic and thromboembolic events that are associated with COVID have a high incidence of mortality. And so our opportunities to prevent unnecessary cases of coagulopathy or thromboembolic phenomena are something that we need to make sure that we're considering for our patients. And then, as always, we want to consider the fact that obviously we're in the acute care space. We have a post-acute considerations and post-acute care colleagues, and we want to address prophylaxis and the potential therapy of patients who have either of these complications in that space, so that way we can potentially prevent hospital readmissions, but more importantly, we are improving the quality of care for the patients who have COVID in the communities we serve. So jumping forward into this, there are key takeaways, and before anybody highlights that you can't read this slide, these slides are obviously available to everyone after the webinar is completed, but this set of recommendations addresses 5 specific areas. Just due to time constraints, we're not going to get into all 5, but want to make sure that the top 2, which are the treatment of patients with COVID, those with mild COVID and post-discharge considerations, and then in the bottom right-hand corner, some of the considerations that we would have for hospitals and health systems are really the 3 areas we're going to address in this webinar. The article addresses them all, and again, we won't be speaking to the components around healthcare workers or funding institutions. So before we get into this, as Nate had done, this article is very similar, quite honestly, to what we call our Tuesday webinars, which are essentially reviews of the existing literature. And this particular article is a panelist statement. It doesn't want to be called a consensus statement because, quite honestly, they didn't come to consensus on everything. But it is a comprehensive review of Medline articles, and these are up through April of this year. That obviously seems relatively recent, but as we've experienced the amount of new information that's coming out regarding COVID and variety of aspects of the disease, make this relevant, but also it's not comprehensive. And so if you've seen something more recent, there's the reason why. The panelists acknowledge that, again, it's existing evidence, but this is a novel coronavirus. The data is typically from small and retrospective analyses and therefore doesn't necessarily meet rigor at the level that we have in terms of statistical significance or can be broadly applied to larger populations. They do use the Delphi method to obtain consensus. For those who aren't aware of the Delphi method, it's a very specific way of asking questions and then anonymously reporting back to the rest of the group so they can see what the answers are with a general migration towards what is believed to be the correct answer. And the questions that they focused on addressing were around prophylaxis and or therapy for COVID patients, whether or not they had DIC. So next slide gets into just a recap of the pathophysiology that we know about around SARS-CoV-2 and the coagulopathic or at least hemostatic complications that are associated with it. First off, in the left hand where it says A, we go over the risk factors, which are the risk factors that we see pretty commonly in all acutely ill hospitalized patients. COVID-19 isn't any different in terms of the risk factors that contribute to potential coagulopathy in there. That leads to endothelial dysfunction, and we see certainly inflammatory response that goes with that. So that's why we notice, again, in the middle section, what the hemostatic abnormalities typically are, which is we'll see laboratory alterations, CRP as one of them, IL-6 for the hospitals that can get that in a quick turnaround, but we're also identified that troponins may be elevated and that there are other issues that come along with this. And most significantly, the clinical manifestations that we see in column C, which are that we're seeing things on the arterial side where there is myocardial injury, strokes, which makes Nate's prior article even that much more relevant. We certainly see a DIC-like coagulopathy. Some define it as DIC, others define it as something specific and unique to COVID, and then venous thromboembolic disease, pulmonary embolisms, and deep venous thrombosis as other clinical manifestations. So again, what we typically see. Next slide starts getting into the hemostasis parameters. And again, the intent here isn't for you to be able to read everything that's in the table, but if we jump forward, it's really an aggregation of the parameters that you want to be aware of as quote unquote common in COVID-19, but also to give you a sense of, hey, is my patient at additional risk? Mild thrombocytopenia and increased D-dimer are commonly seen, and at least in the articles that were reviewed here, do indicate an increased risk of mechanical ventilation and death. There is a tremendous amount of heterogeneity with respect to how other laboratories show up. And in fact, the article cited that in many instances, it looks like the laboratories can be contradictory. And so when we're thinking about coagulation and coagulation cascade and commonly obtained labs, PT and INR, shortened APTT, are relatively common, but they have again, the variable association of disease severity, as is noted here on the slide. Now, part of the reason why we're making sure to consider this aspect of what's going on with the laboratories is also to think of the fact that we're going to be discussing anticoagulation, antiplatelet treatments. And the simple fact of the matter is that now with COVID-19 in the background, there's material effect on what is occurring with the drugs that we are administering for our patients. And we've spent a lot of time, and a lot of people are eagerly seeking additional treatment regimen, most of which are investigational. And of interest is if we are considering anticoagulation, whether on the venous side with anticoagulants or on the arterial side with antiplatelets, you want to at least have a sense of, hey, are there concerns that I need to be thinking about, particularly if I'm involved in a hospital that is using some of these investigational therapies? So the next slide really gets a little bit more into the detail of what was on the prior slide. We've reported out in prior webinars, and what is surfaced in this particular report is that lopinavir and ritonavir, what's commonly known as Kaletra, vitamin K antagonists that are listed typically have dose adjustments. And then there are two anticoagulants, edoxaban and rivaroxaban, that shouldn't be co-administered with lopinavir, ritonavir. Something, again, that we want to consider if we're at hospitals that are using this particular regimen. And then tocilizumab, no dosing adjustments are required. For a lot of the other investigational agents, and this certainly wasn't an exhaustive list, there weren't a whole lot of drug-drug interactions. But part of the reason I believe that the authors wanted to make sure that this was highlighted was that we potentially increase the risk of potential bleeding, but we also need to make sure that that dosing considerations are being made when we are providing prophylactic anticoagulation for our patients, hospitalized patients. The next slide is the exact same comment, but focused on the antiplatelet agents. And if we move forward to the next slide, same issues with lopinavir and ritonavir. There may be a reduced effective dose of clopidogrel because of cytochrome P3A4 and an increased effects in ticagrelor. I can almost never say that one properly, but they do offer suggestions in terms of an alternative medication that doesn't necessarily have the cytochrome P3A4 interactions. Nothing is known about remdesivir. And as far as the other investigational therapies, again, nothing that has been noted with the parenteral antiplatelet agents. And again, Nate highlighted a couple of those that were in his study. If we move forward, I think that the heart of what we want to get into is the VTE prophylaxis risk stratification. And looking at this pyramid, on the left-hand side are really, again, any concept of increased risk and whether or not anticoagulation should be used, which is highlighted on the right. What comes out of this particular report is ultimately that everything that isn't in green, which essentially indicates all hospitalized patients, require some level of VTE prophylaxis while they are in the hospital and potentially when they're outside of the hospital. If you jump forward to the next slide, this gets into the WHO interim recommendations. And I'm going to walk through this particularly slowly because I think a lot of what's in here is incredibly germane to our hospitalist practices, and quite honestly to our SNFist practices, and something that should be our emergency medicine colleagues and critical care colleagues should be aware of as well. First off, the general recommendation is if you have COVID and you're in the hospital, the recommendation is low molecular weight heparin or twice daily unfractionated heparin. I underscore the first bullet point most significantly, which is missed doses are typically associated with worse outcomes. Worse outcomes are typically mechanical ventilation and death. And so I know that there are lots of times where patients may be refusing doses. There are potential procedures that may come in or any other timing, but I do want to underscore that in this particular instance, patients with COVID missed doses have absolutely worse outcomes, and so we should be very thoughtful in times where we are reserving our VTE prophylaxis. Again, from the consideration of the nursing interactions with the patient and the number of times that they're dosing, low molecular weight heparins are preferred. Again, what's listed there, less personnel exposure, less PPE use. There isn't any evidence for our heavier patients on whether or not there should be any weight adjustment, and pregnant patients, unless there is a very clear reason why they can't be prophylaxed, you need to be considering what appropriate chemoprophylaxis is available. As with everything that's going on with VTE prophylaxis, if a patient is absolutely contraindicated against it, the recommendation is that the patient should have TED and SEDs, TED hose and SEDs placed. The SEDs need to be on and they need to be working, because we get back to the first bullet point, which is that's if they are on and they are not, and the compression devices aren't active, that's considered a missed dose and there are potentially worse outcomes. The next slide are about, again, areas where there isn't consensus, but it's certainly a question that is continuing to be asked. There aren't reports and aren't significant data around what to do for extended or post-discharge prophylaxis in COVID patients. And again, despite using the Delphi method, they didn't really come to a clear consensus in terms of what should be done. The majority of panelists in this report stated that thromboprophylaxis should be considered for high-risk patients for up to 45 days. And what you see in the 3 bullet points aren't an exhaustive list, but it should be part of your calculation in terms of discharging a patient and what should be done for them, whether it's to a skilled nursing facility, rehab, or even to home. If they're a high-risk patient, you want to make sure that you're considering this. The last bullet point is really for the, they called it the mild COVID-19 patient. And this, I think, is really stating if you have COVID at home, but you're mild and you didn't require hospitalization, then you really shouldn't be considered for thromboprophylaxis. But again, those aren't commonly patients that we would see. The next slide is also a consensus statement that came from this, and I found this particularly interesting because this really was, the article really focused on limiting exposure of others with respect to procedures. And as you can see, catheter-directed therapies, they recommend that only very specific subset of patients should receive these therapies. Overt hemodynamic instability, and again, if systemic fibrinolysis isn't suitable, then it could be considered. But in general, they were leaning very heavily towards systemic fibrinolysis as the primary choice of intervention for patients who may have thrombotic complication, and were against any catheter-directed therapies. The same essentially goes for IVC filters. They generally felt that these should be avoided in cases where, avoided except in the cases of recurrent PE. And again, it's in cases of recurrent PE with optimal anticoagulation. They continue to emphasize that the focus should be on anticoagulation and optimizing that, and then delaying any other procedures. In the instance of patients that needed to go to a cath lab, they did discuss systemic anticoagulation for those patients, but they also made a statement that assuming that infection parameters are the same in all areas, patients should be considered to be in an intensive care unit using ECMO as opposed to an operating room or a cath lab. They had references about specifically why, and I did not dig into those specifically, but that was one of the recommendations that came out of this particular article. The last slide is finally, oh, sorry, this isn't the last slide. It's the penultimate slide. The other things that were in terms of diagnosis and management, and again, no consensus here, were how to evaluate patients for suspected venous thromboembolic disease. And they said, first off, getting a D-dimer doesn't help you. It's typically already elevated in COVID. And so it doesn't help you rule in or rule out disease. And in the general case, routine CTs or lower extremity ultrasound may lead to unnecessary exposure to other caregivers in the place of a patient with a high level of suspicion. Again, not consensus, and so no clear recommendations, but the majority of the panelists basically said high index of suspicion, you should go ahead and treat and consider therapeutic dosing. There were others that made other recommendations that were listed, but again, no consensus clearly identified here. This final slide was one that I really thought would be of interest. And again, it's a bit of a challenge to read, but in considering what to do for a discharged patient or patients that may now have limitations with access to overall care, this is a framework by which patients should be considered for what the approach is and potentially to switch medications. So on the left is really, hey, we have patients who are on warfarin. How can they stay on warfarin, and what makes it safe so that way they can make sure that they get INR checks? On the right is basically saying, hey, the patient has a subtherapeutic INR or has one that is overly elevated, and what the options are, including evaluating whether or not there are options for in-home or drive-through INR testing or making additional arrangements. But I do think that this is a particularly good piece of information, not only for our hospital medicine colleagues, but for our colleagues in the other specialties, because we do have to consider medication alternatives in the environment where patients may not necessarily have access. And these are part of the approach of addressing coagulopathies within COVID-19. So with that, that is our final slide, and I too will await any questions should anybody have them.
Thank you, Greg. Let's give it a few moments. All right, it appears that we do not have any questions today. Of course, if anyone has any questions or thoughts in follow-up, you have the option to use the still functioning COVID-19 at Sound Physicians email address. You can also reach out to Nate and or Greg directly. Their emails are listed here on the slide as well. And of course, you can always find them in the email directory. Please make a note, it should be on your calendars already. Our next webinar will be October 1st. That is, of course, the first Thursday of the month, and we will be continuing in this new format. We'll have an article that's relevant to COVID-19 practice, and that will be paired with another clinical topic of importance. Always, always, always want to remind you that there are resources available to you as we are all continuing to navigate this pandemic and the extraordinary demands it is placing on many of us in the course of our day-to-day work. Please know that you can avail yourself of Sound's peer support service. That is an opportunity to receive, to have an interaction with a trained peer to help you process a particular encounter you may have had, any sort of unanticipated or negative event related to patient care. There's a toll-free number to call, and that number is available 24/7. In those instances where you would benefit from some more longitudinal support around an issue or just simply dealing with the increased stressors that we are all facing these days, Sound's Employee Assistance Program is a fantastic resource. It's available not only to all of our colleagues, but also to family members. So please make note of that toll-free number there. And last but certainly not least, our colleagues in People Support, our Human Resources Division, are always standing by. I'm going to take just a moment to check the questions one more time before we close out. Stephen, I saw in the chat from you that we have questions, but I can't see them in my view.
There's 2 questions popped in. The first question is, any recommendations for alterations in duration of post-discharge therapeutic anticoagulation?
So I'm going to repeat the question and make sure that I'm answering it, that any recommendations on the timeline for post-discharge therapeutic anticoagulation. And if I got that right, then the recommendations around timeline have not changed for patients who require therapy for, I'm assuming, new onset venous thromboembolic disease. It's typically 3 to 6 months based on whatever the whatever the condition is, and obviously it's dependent on what has occurred with the patient previously. But there is no change in terms of therapy for long-term, for the typical treatment course for a patient with venous thromboembolic disease, even with COVID.
Thank you, Greg. The other question that popped in is full anticoagulation ever recommended prophylactically?
So that goes back to the slide, and if you wouldn't mind scrolling back, Fabienne, there was a no consensus on that. One more. Sorry, go forward. So it's actually the one that says post-discharge, and I think that is not necessarily directly answering your question, but in this particular report, there were a minority of the panelists who recommended that in certain instances of a patient that was considered high risk, that you move to full dose anticoagulation. There's, again, not data to support it, and it's ongoing study, but from this particular report, there isn't a specific recommendation one way or another. There are people that are considering it.
Thank you, Greg. Those were the only 2 questions I see.
Thank you, Stephen, for calling those out. I'm glad that we got to address those live in a moment. And again, want to remind folks about resources. We look forward to seeing you at the next webinar. The slides and the recording will be posted. Just so you know, there is an appendix to the slide deck that includes some of the tabular data from the study that Nate presented about stroke management, so you'll have that as reference as well. For now, I will thank you for being with us. Thank you for all of the work that you are doing at the bedside and to support your communities, and for taking the time out to join us today to learn how to continue to improve and evolve your practice. Thank you so much, everyone. Be well, and we will see you at the next gathering on October 1st.